Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, for the talk today.
Thanks, Kent. Well, today we're going to talk about antiretroviral switch studies, and this is going to be an update. I did one talk on switch studies about a year ago in July 2013 when we talked about some of the pivotal switch studies like SwitchMark and Spiral, and we talked about some of the things that we learned from those early switch trials. So this is really going to be an update of switch studies that have come out in the past year. And I'm going to start with just a clinical case and a question for you to think about. This is based on a real case. This is a 45-year-old HIV-infected gentleman who comes in for follow-up. He was diagnosed with HIV about a year ago, at which time his HIV RNA or viral load was 175,000 copies. And on his baseline genotype resistance assay, there was a K103N mutation, so a transmitted K103N. He started antiretrovirals with tenofovir emtricitabine, which is Truvada, darunavir, which is Prazista, and ritonavir or Norvir 9 months ago. His viral load is now undetectable, but at this routine clinic visit, he's complaining of stomach cramps and loose stools, which started with the meds, and he also says he wants fewer pills. Really what's happened is he's heard that there are 1 pill a day options out there, and he really wonders why he's not on one and wants to be on one, which is not an uncommon clinical scenario. So here's what I'd like you to think about. Would you offer a switch to this gentleman to either of these regimens, either of these 1 pill a day regimens? So the first being tenofovir emtricitabine rilpivirine, which is Complera. The second being tenofovir emtricitabine elvitegravir cobicistat, which is Stribild. And then would you maybe offer him either of these as options or neither of these as options? Remember, this is a person who had a baseline viral load of 175,000, but now he's undetectable. He did have a baseline K103N, and he's just dealing with some side effects and maybe pill burden from his Truvada and boosted PI. So I'll let you ponder that for a second. If he comes in wanting 1 pill a day, wanting less side effects, would you offer him Complera? Would you offer him Stribild? Would you offer him both or neither? And we'll talk about some of the data that gives us a little bit of guidance in this situation. And we'll talk about some things to think about. So just stepping back for a second, the reasons to consider antiretroviral switches if somebody is suppressed, meaning their HIV is well controlled, which this does come up. So really today we're talking about ART switches in the setting of a suppressed viral load. We're not talking about switches for resistance or for virologic failure or other things. That's a different talk, and we've covered that a little bit in prior echo talks. Here we're really talking about switching in the setting of a suppressed viral load. So why would we want to do that? I think the most common scenario that comes up is because of side effects. Other possible reasons we'd be thinking about this with patients is maybe to reduce pill burden or dosing frequency. Maybe a new drug interaction has come up. For example, maybe a person's GERD is worsening and they need a high-dose PPI, and you've got to get them off an ARV that has an interaction. The HHS guidelines list also food requirement, and they also have a discussion about cost. I'm not really going to focus on cost today, though the 2014 guidelines do have a discussion about that. In my experience, it hasn't been a frequent factor for which we have to change meds, but in the coming years when more antiretrovirals become generic, such as efavirenz and tenofovir in a couple years, cost may become a more frequent factor in considering switches. I would say the most common reasons we talk about switching in the setting of a suppressed viral load are side effects followed by pill burden. Now, I did do a talk covering some of the early switch studies back on July 18th, 2013. You can go to our NWAETC Echo website and watch that talk. There we talked about some of the early pivotal switch studies like SwitchMark and Spiral. And some of the things we learned from those studies. We learned, especially from SwitchMark, that some switches are risky, especially if an individual has prior virologic failures, especially if they have prior resistance. And then from studies like Spiral, we learned that switching from a regimen with a higher barrier to resistance to a regimen with a lower barrier to resistance may be successful in select patients. And one of the things we're going to focus on today is, well, what criteria makes somebody more likely to be successful with such a switch? And who are these select patients who probably can switch successfully? Because that's one thing that's come out of switch studies in recent years. It's essential to review a few things with a patient if you can before making a switch, especially before making this switch from a regimen with a higher barrier resistance to a regimen with a lower barrier. For example, switching a boosted PI to something with a lower barrier to resistance, like any of the current single tablet regimens, or switching to Truvada-Raltegravir or something like that. So if you can, you really want to review a person's entire antiretroviral history, their past virologic responses, their prior resistance history, prior intolerances to medications, and any concurrent medications for drug interactions that may come up with a switch. I think the challenge that we've all seen or we've all dealt with is when a patient transfers care to you, they're already on a regimen, they want to switch, and you don't have this data available. Maybe you can't get past resistance data, or the patient doesn't know their entire ARV history, and you have trouble confirming all the regimens they've been on. I think that's a common scenario we've all dealt with, and there it becomes a judgment call. And I would say I'm generally pretty cautious when I switch in that setting from a regimen with a higher barrier to resistance to a regimen with a lower barrier to resistance. But it really becomes more of a judgment call, and sometimes takes getting to know the patient and putting together the data as best you can. These are the switch studies I'm going to focus on today. The SPIRIT study, which looked at switching from a boosted PI to Complera, and then the two STRATEGY studies, which were just published in Lancet Infectious Diseases. STRATEGY PI, which looked at switching from a boosted PI to Stribild, and STRATEGY-NNRTI, which looked at switching from an NNRTI-based regimen to Stribild. And then I'm just going to mention a couple other new and upcoming switch studies. To start, this is the SPIRIT study, which looked at simplifying two rilpivirine, emtricitabine, tenofovir, or Complera from a regimen with a boosted PI. And here's the basic study design. So this is a prospective, randomized, open-label, ongoing phase 3 trial that is industry-sponsored. So I want to emphasize here, this is an open-label study, and it is industry-sponsored, as are many switch studies nowadays. And the inclusion criteria are extensive for this study, meaning they selected patients very, very carefully to enter this trial and to randomize to switching or not. The inclusion criteria are so extensive for this study that they had to include a supplement to explain them all. And I think the point I want to make here is that in a setting like this, where you're considering switching from a regimen with a high barrier to a regimen with a low barrier resistance, you do have to select patients very carefully for them to have a chance of being successful with that switch. Otherwise, it can be risky. So, for example, what were their inclusion criteria? So, all participants had to have a viral load that was suppressed on a boosted PI plus 2 NRTIs for at least 6 months with no history of virologic failure, only on their first or second regimen. So these were not patients who had been on a slew of prior regimens. And they confirmed resistance history in all of the participants, and they had to have no resistance to any of the study drugs or NRTIs. And so again, these are very carefully selected participants, because you're switching from a regimen with a higher barrier to a lower barrier to resistance. And the primary endpoint here is the proportion with a viral load less than 50 copies at 24 weeks. And they randomized 2-to-1 to either switch from the boosted PI to tenofovir, emtricitabine, rilpivirine, or Complera, here in the green box, or to continue the boosted PI and the NRTIs. And so they randomized 2-to-1 here in this immediate switch arm, and then their primary endpoint was a suppressed viral load at 24 weeks. And then at 24 weeks, they also switched all those individuals who had continued their boosted PI over to Complera, so that in this second phase of the study, or this delayed switch phase, everyone was on Complera, and they collected data up until 48 weeks as well. So the baseline characteristics were very similar between the two groups. In this study, the participants were primarily male, primarily Caucasian, and overall had very well-controlled HIV with a median CD4 of 588 and a median time on antiretroviral therapy of 2.75 years. And there was a mix of the boosted PI that participants started out on between atazanavir, lopinavir, and darunavir. The NRTIs primarily were tenofovir, emtricitabine, or Truvada. And again, I think the data here in terms of baseline characteristics is just showing you that overall these are individuals with very well-controlled HIV. And here is the primary data, which I've just summarized in this table. So their primary outcome in this first box is the viral load less than 50 copies at 24 weeks. You can see was not statistically different. So this switch, again, in very select patients, was successful and was non-inferior. There's a couple things I think are really important to mention out of this study, and these get at these next two columns. So looking at this next column, the HIV RNA or viral load less than 50 copies at 24 weeks, if the baseline viral load was above 100,000. So these are participants in whom their baseline viral load was above 100,000, but now they are undetectable and they're switching to Complera now that they're undetectable. And you can see that those individuals did really well. Because the question that comes up in clinic is, well, let's say a person had a baseline viral load above 100,000, so Complera is contraindicated. Now they've been on a different regimen and their viral load is continually suppressed, but maybe they're having side effects or struggling with pill burden. The question becomes, can you switch them to Complera? So this data here would suggest that yes, you can if the viral load is now continually suppressed. Again, these are in very select patients who haven't been on a lot of prior regimens, don't have known past resistance or a lot of prior virologic failures. But this would suggest that in that setting, that baseline viral load above 100,000 is not a contraindication to Complera if they are now suppressed on an alternate regimen. In this next column, I think this is also important to note, they looked at those participants who had a baseline K103N mutation. Overall, there were 24, and you can see there was a very high 91.7% of virologic suppression rate in those at 48 weeks. So this is a composite of the early and delayed treatment arms. And you can see what I put here at the bottom in the bullet point. So of the two participants who were not suppressed at 48 weeks, one of them had an additional baseline NNRTI mutation that was in addition to the K103N and developed additional resistance mutations. The other was counted as a failure, but that was because of missing data at 48 weeks. So actually the number here might be a little bit higher, might be 23 out of 24 suppressed. So we know from in vitro data that rilpivirine in Complera should be active in the setting of K103N. There just isn't much clinical data to confirm that, and I think this is the best clinical data we have so far. So here from the SPIRIT study, it does appear that rilpivirine or Complera is quite active in the setting of a K103N mutation. Looking at the next columns, lipids, not surprisingly, improved, switching from boosted PI to Complera. And then if you look at the last column, the change in estimated GFR, there was a small decrease in estimated GFR with a switch to Complera, which is consistent with known effects of rilpivirine, causing blockage of tubular secretion of creatinine, but this did not lead to treatment discontinuations and likely did not lead to decreases in actual GFR. So here's just what I'm taking from the SPIRIT study, or a brief summary of lessons learned from this. So at least this is my interpretation. So the switch to tenofovir, emtricitabine, rilpivirine, which is Complera, from a boosted PI into NRTIs may be safe and tolerable for very select patients. And I'm putting very select patients because their inclusion criteria here were so strict. And so this is not a switch I would consider if someone has a lot of prior virologic failures, a lot of prior regimens, prior NRTI resistance or anything like that. But for patients who are only on their first or second regimen, who are very adherent, whose viral loads are continually suppressed, I do think this is a switch we can consider to decrease side effects and decrease pill burden. And then what I talked about, the pre-ART viral load above 100,000, although we know that's a contraindication to Complera, it does appear that if somebody has taken an alternate regimen and their viral load is now continually suppressed, now we can consider a switch to Complera. And then it does appear that a baseline K103N mutation by itself does not contraindicate Complera, and not surprisingly, switching from a boosted PI to Complera does lead to improvements in lipids. So I think those are the lessons I'm taking from the SPIRIT study. I encourage you to look at it yourself and draw your own conclusions. But I do think although there are some limitations to the study, I do think there are some very valuable things to be learned from it. So with that, I'll switch to the two strategy studies. And the strategy studies both look at switching to Stribild, the combination pill Stribild. This first study, Strategy-PI, looked at switching from a boosted PI and Truvada to Stribild, and here's the design. So again, this is a prospective, randomized, open-label, ongoing phase 3 study, again industry-sponsored. Again, they had pretty strict inclusion criteria, including a viral load suppressed on the boosted PI and tenofovir, emtricitabine, or Truvada for at least 6 months, a creatinine clearance above 70, because that's one of the requirements for Stribild in the package insert, no tenofovir or emtricitabine resistance, again on first or second regimen only, and no history of virologic failure. So again, these are individuals who have well-controlled HIV, have generally been very adherent without a lot of prior regimens, without prior virologic failure or resistance. Their primary endpoint here was a suppressed viral load at 48 weeks, and they randomized 2-to-1 to, in this green box, switching to, this is elvitegravir, cobicistat, emtricitabine, tenofovir, or Stribild, or continuing the boosted PI plus tenofovir, emtricitabine. Like the previous study, participants were primarily male, primarily Caucasian. You could see about 40% were on boosted azanavir, 40% boosted darunavir. The median time on ART was about 3 years. Only 19% were on their second regimen. So participants in the study were primarily on their first regimen, and baseline characteristics were similar between the two groups. And here is a just composite of key results. And in this first column, I bolded the response to Stribild because it was statistically significant when compared to the virologic response in those who stayed on the boosted PI and Truvada. However, I would encourage a lot of caution in interpreting that because of this bottom bullet point you can see down here. The most common reason for enrolling in the study was wanting to simplify. 86% who enrolled in the study, based on a survey, said they enrolled because they wanted to simplify. So here, I think, is just something that makes it tricky to interpret switch studies. You have a lot of people who enroll in these studies because they want to switch, but then all these current studies I'm showing you are open label. So people enroll because they want to switch, and then they know if they didn't switch or not. And so here, what we're seeing is more people dropping out of the study in the no switch group, not because of virologic response, not because of resistance, not because of side effects. And so you have to wonder if they're dropping out just because they wanted to switch and they didn't. So I personally would not interpret this as the switch to Stribild being superior. I do think it's reassuring, and we can probably at least say it's non-inferior, but I would not be confident saying that switching to Stribild is superior, just given all of those factors. But at least I think we can say that the switch to Stribild in this select group of patients is non-inferior. And then you look at the other columns, the rates of virologic failure were very low and not statistically different. Same with the rates of side effects. The change in creatinine clearance, or estimated GFR, consistent with the known effects of cobicistat, which also blocks tubular secretion of creatinine. Estimated GFR, or creatinine clearance, did decrease, but this did not lead to treatment discontinuations and is not thought to be clinically significant. And then there was only a very mild decrease in triglycerides. When comparing the lipid effects, there was more benefit for those who switched from Kaletra to Stribild as opposed to switching from other PIs to Stribild in terms of lipid effects, and that's not surprising. But really, when we look at the more modern boosted PIs switching to Stribild, there was not that much benefit in terms of lipids, except only this tiny decrease in triglycerides. The other thing I was interested in was whether there would be any improvement in GI side effects, because a lot of people struggle with GI side effects with their boosted PI, primarily because of the ritonavir. We also know there are a lot of GI side effects from the cobicistat and Stribild. So I was curious, is there any real difference? And in looking at this, in those who switched to Stribild, what they reported was some improvement in diarrhea and bloating, but higher rates of nausea. So I think it's really a wash in terms of GI side effects and whether there is any improvement in switching a boosted PI to Stribild. I think some individuals might experience improvement and others probably would not. So then turning quickly to STRATEGY-NNRTI, which really was the same design, except here switching from an NNRTI with tenofovir emtricitabine, which is Truvada, to Stribild, and very similar to the prior studies. Again, very carefully selected patients, very strict inclusion criteria, which were very similar to the prior studies, and again, randomizing 2-to-1 to either switch to Stribild or continue the NNRTI plus Truvada. Like the previous studies, primarily male, primarily Caucasian, you can see 78% were on efavirenz, 17% on nevirapine, and the median time since first ARV use was 3 years. Here, 31% enrolled because of current or long-term side effects. So again, you have a fair number of people enrolling because they're hoping to switch. And here's just a brief composite of results, and really what I would say is that there was no difference. So switching to Stribild as opposed to continuing the NNRTI-based regimen was non-inferior. This difference here between 93 and 88% virologic suppression at 48 weeks was not statistically different. Very low and equivalent rates of virologic failure, low rates of grade 2 to 4 adverse events, and again, the change in creatinine clearance is just consistent with the known benign effects of cobicistat. A couple other things from this trial. When looking at lipids, there were small improvements from baseline in those who switched from efavirenz. So switching from efavirenz or a triplet of Stribild, based on this study, we could say might lead to small improvements in lipids. but they were not vast improvements. And then not surprisingly, switching from efavirenz or a tripla to Stribild led to improvement in neuropsychiatric symptoms, which is consistent with other switch studies off of efavirenz-based regimens. So just a couple things that I'm taking from these strategy studies. So the switch to Stribild from a boosted PI or NNRTI-based regimen is likely safe and tolerable, again, for select patients. So especially if you're going from a boosted PI to Stribild, which is switching from a regimen with a high barrier to resistance to a regimen with a low barrier resistance, I think we have to be very cautious. And really, we think that can be successful in select patients who do not have a lot of prior virologic failure, do not have a lot of resistance, have not been on lots of prior regimens. So we really need, I think, to think through who we are making these switches in. And then the switch from, especially efavirenz to Stribild may cause slight improvement in lipids and should improve neuropsychiatric symptoms. Just the last slide to wrap up, other new and upcoming switch studies. So study 123 is a study of switching raltegravir to Stribild, and I couldn't find that published anywhere, but it was presented at IAS 2013, and the data is available online. So if you're considering that switch, just wanted to show that there is some data available. You can find the results online. It was a small study, only 48 participants if I remember right, but if you're considering that switch, just so you know, there is some data out there. And then a couple of studies that are either upcoming or ongoing. So the second one, DORIS, is a switch from a 3-drug ART regimen to the 2-drug regimen of dolutegravir plus rilpivirine versus continuing 3 drugs. So I think that will be very interesting to see. If I remember right, I don't think that study is yet enrolling, but it is planned. MARCH is an ongoing study. It looks at switching from a boosted PI plus 2 NRTIs to Maraviroc plus a boosted PI, so a 2-drug arm there, as compared to the 3-drug arm of Maraviroc and 2 NRTIs, or continuing the 3-drug regimen of a boosted PI plus 2 NRTIs. So there may be some very interesting results from that. And then this last one doesn't have a clever nickname that I know of, but I do think it will be interesting. So this is looking at switching from a boosted PI to dolutegravir, and is going to look at virologic outcomes, but also is going to focus on cardiovascular risk and markers of inflammation. So not surprisingly, we're going to start to see in the very near future some switch studies to dolutegravir.